thank you very much, and thank you all for being here, and thank you to Dr. Siegel-Vidon for inviting me here to speak about the Alzheimer's Primary Care Detection Toolkit. And give me just a second so I can arrange these things here. First of all, I want to tell you my objectives for this talk are to describe this toolkit and the development of it, outline its key components, and identify how it's structured to help you provide identification and prevention due to Alzheimer's disease. You've heard about how useful it is to diagnose Alzheimer's disease and make the diagnosis early, and why that is important. It's important to realize that there, as Dr. Siegel-Vidon mentioned, there will be drugs. Eventually, they're coming down the pipeline, and so primary care will need to be able to diagnose Alzheimer's disease. And these drugs, we hope, will not only be effective, but we hope have reasonable side effect profiles. And primary care providers will it'd be important for them to differentiate between normal aging, Alzheimer's disease, and those things, typical Alzheimer's disease, and those dementias that are more difficult and maybe need a referral. There are not enough neurologists alone, let enough dementia specialists to be able to diagnose all of those people. So the idea is have a toolkit that will help primary providers differentiate between the patients that can be kept in their practice, the normal aging, the typical Alzheimer's disease, and those that need specialized referrals. So I think this is a difficult undertaking, and I think that one of the things that we tried to do with this toolkit is to provide a little neurologist that can ride on your shoulder and help you do that. Okay? It's easier said than done. But the toolkit is the ACCT-AD. That's a mouthful, but basically it's Assessment of Cognitive Complaints Toolkit for Alzheimer's disease detection. Okay. Now, there are a lot of guidelines out there already, so why do we need another one? Okay. So I'm going to just go through a little bit about how these guidelines are in general set up, and then I'll tell you a little bit about why we developed one that's slightly different and how it differs. And I hope everybody can hear me. So, first of all, I'd like to give a shout out to Dr. Howie Rosen, who provided many of the slides for use in the lecture. So if you like the slides, it's Dr. Rosen. If you don't like them, it might be because I adjusted some of them a little bit. But so there's plenty of guidelines out there for assessment, and they all start with a similar kind of basic structure. Okay, and the first one you see here is in the CARE model: kickstart, assess, evaluate, and refer. And if you look at what they do first, most of these models have a brief assessment of cognition. And if you pass it, okay, that's fine. And here's one. Another one is the Alzheimer's Clinical Roundtable. They also start with a screening visit. And then the Alzheimer's Association has a flowchart that also starts with a screening visit. And then if you pass it, great. If you don't pass it, they go on to and I apologize, these boxes moved for some reason, maybe because I developed it on a Mac and now it's being shown on PC, I'm not sure. But if they're positive, you proceed to a full evaluation, or you need to do a referral. We were talking about why referrals may be problematic. There's not enough specialists, and also sometimes those referrals never connect with the patients for one reason or another, including the fact that it's kind of a bit of a shortage of specialists. Let's see. Here's all of these have their own role. And what does that full cognitive assessment mean? I think that's something that maybe can strike fear in the hearts of people who are not initiated. Even neurologists who are not specializing in dementia are going to find that they're like, well, what do I exactly say? And all these standard cognitive assessments are very complicated. There's a lot of difficulty with the history and the onset, the nature of the impairments. Are there associated behaviors? Maybe there's psychiatric issues, medications that are part of it. What about the functional assessment? And this is just from one of them, from this care that talks about all the different things that need to be done. And the question is, A, how do you know how to do all these things? And B, how do you get them done in a 15-minute visit? And that you may need more than one visit, but just so you know. So all of these guidelines that are out there kind of start with that brief assessment, and then they do this more deep cognitive evaluation, which can be overwhelming in the primary care setting. So the CADCs, or the California Alzheimer's Disease Centers, of which we are one, Dr. Stigo Gidan is one, and UCSF main campus, there's 10 of them, got together and cooperatively decided to address the gaps in this existing guidelines. And this is work that's been sponsored by the CDPH, the state of California, and we've found that the accuracy of the history, as all of you know, depends on what questions you ask, and then how you interpret the answers. And this is where that little neurologist on your shoulder helps to tell you what kind of questions you may want to ask, and then how do you interpret them. For example, if you ask about behaviors, and then they say, well, the patient is yelling and screaming at family members. Well, is this actually disinhibition and diagnostic of FTD, or is it just that the patient is frustrated because the family members don't necessarily understand how to interact with somebody that has dementia and are kind of setting them up to fail in a way? And that might just be typical Alzheimer's disease, and maybe family education would be one way to really deal with this. This is where many primary care providers find themselves to be a little bit uncomfortable. They don't know how to, A, exactly what questions to ask, just kind of general questions, and B, how to interpret the specific answers. Another gap that we found was there's cognitive testing recommended in the guidelines, but it may not have details about exactly how to use it, which ones to select, and that sort of thing. So that's not always specified in these guidelines. Also the issue of how to deal with non-English speaking patients, which is not an unusual occurrence, and how to deal with low education, which again in certain areas is going to be not uncommon either. So another area that we felt that primary care providers might have some discomfort with is how to present the diagnosis. And that may be one reason that providers feel better off going to a specialist for the patient, because, the specialist will know how to present this diagnosis. Okay? And so those are the gaps that we were interested in addressing with the development of this toolkit. So, what was our goal? Our goal was to allow primary providers to do more of the full assessment in primary care, and then judiciously use referral. As you've heard other people say, as I've already said, there really are not enough specialists to see all of the patients with dementia that are coming in this tsunami that we're going to see. And as we develop drugs that are effective, we're going to need to even more it's going to be super important to identify them and get them the correct treatment. And you may say, well, I heard about blood tests, I heard about this, I've seen things are coming down the pipe as far as diagnostic, Well, the problem is there may be multiple reasons for someone to have dementia. You also know that the problems with Alzheimer's disease pathology can be laid down a decade or more before patients are actually symptomatic from that. So they're showing up symptomatic in your office. How do you know if that's because they have Alzheimer's disease or something else, they may have a test and it may be positive, but that's not why they have their symptoms. So there's still going to be use for this type of work, even in the setting of many possible tests. There may be tests that are developed that are so specific and so sensitive that we don't need to ask any questions anymore, but that's very unusual, even in any other kind of setting. So you do have to know how to do good histories, etc. So the idea is, with the use of the toolkit, the normal aging, Alzheimer's disease, typical Alzheimer's disease, can stay in primary care and will not need a referral. Those that bump up against red flags or show that there's something else going on are going to need a referral. And the toolkit's goal is to kind of bifurcate right there, okay? So the ACCT-AD toolkit guides primary care providers to differentiate between normal aging, typical AD, and then unusual dementias. It's developed by the experts in a collaborative process. In our group of CADCs, there are many experts who are national and internationally renowned for their expertise in dementia. So this is a very, great group of people to work with. It is a complete guide for the complete assessment. It allows the diagnosis. It identifies signs and symptoms that suggest needs for referral, and it guides on how to disclose the results and to, there's other things, and I'll talk about some other key things like how to talk to patients about driving. I don't know if any of you have problems with that, but that's one of the most difficult things about making the diagnosis. And certainly, I have a colleague who says, some patients with dementia may not remember a lot, but they always remember the doctor who reported them to the DMV, okay? And primary providers may not want to be that person, and that may be one of the reasons for referral, but this toolkit does help with how to present the necessity to make the report to the DMV. It is a California-developed toolkit, so it specifically addresses the California legal requirements about reporting. For those of you who may not be familiar with other states, not every state, and I think the majority of states do not require reporting quite with the strictness that California does. In some of the states, the patients are the ones who are supposed to do the reporting, but I think California decided that if they have dementia, they might not remember to report, so it makes sense. But it does interfere with that doctor-patient relationship at times. All right, so now's the complicated part. The toolkit was developed with the 10 CADCs, okay? And everybody got together and, certain people worked on the memory questions and other people worked on the visual spatial questions and other people worked on the scripts at the end. So it was a collaborative effort. We got all together, we reviewed everything, we said great. And it was put out as two things. One, an instruction manual, which is a blue. And so if you Google this toolkit, ACCT-AD, right? If you Google this is what you'll find, and you'll find an instruction manual, which is about 5 pages long, and it kind of goes over how to use it. And then there's a reference and interpretation manual, which is really the meat of it, and it's really long, and it has all the flow sheets about how you do the questions and what questions you ask and what answers you might expect and that sort of thing. It also provides guidance at the end for how do you do what kind of labs and imaging and how do you counsel patients and when to make a referral, and has some information about billing. So and that is the yellow. So that's the yellow thing, okay? There's a group that's spearheaded by Dr. Rosen and the UCSF main campus group that is using a grant from the state to revise and update the toolkit to make it
more accessible to primary care practices in the real world. And I think you'll hear a little bit more about that in the next panel group. This is still a work in process, and the idea for this is based on focus group data that showed that the original formatting in this kind of yellow thing that you can find was difficult to follow. And the goal is to make a toolkit that is practical and to have options so that primary care providers and primary care practices can tailor the toolkit to the needs of their particular clinic. And different clinics may have different needs. They may only want to do the screening portion, or they may want to do the full assessment, or they may want to, and who does what portion and how they break it out. And we'll talk a little bit more about those things. And you should have available the links to the original toolkit and from some of the updates. So we'll talk about that as well. So what is this ACCT-AD toolkit? It, like some of the other guidelines, is a step-by-step approach to the cognitive assessment. And again, you complete the detection, then a full exam, then you have a manual to help you review and interpret the information that you've collected, and then you have help with the results and the disclosure. So it's a complete process. Again, think of that neurologist. If I had a cute little picture of a neurologist on the shoulder, I would show you, but I don't. Just imagine it right up here. So it mirrors some of the setup of some of those other guidelines where I told you there was a brief assessment. Ours is a detection assessment, and that's available in a couple of different ways and a couple different forms. UCLA developed and the CADCs adopted a wellness visit screening tool. It's a flow sheet, and that link should be somewhere in the available to you. If it's not, we'll make sure you get it. But this is a 2-page thing. You can just have it in your clinic. It leads you through the questions that are our detection questions. There's a set of 3 questions involving memory, language, and behavior. You do that with the patient. If those are all great, you go on to 3 more questions in each of those sections. If that's perfect, then you go to see the informant and you do the same questions there. And if everything's fine, you're good to go. And that screening tool will do that for you. The grant with the updated toolkit also has forms that will do that in either a printable or a fillable PDF, and also as a smart phrase in some of the EMRs. So that's available as a result of development from this grant. Now, remember, these grant tools are in progress and they're still being worked on, but because you're here at this thing, you have access to that as well. Then the next stage after the detection assessment, if they have any questions that are positive, if anything is abnormal, then you go on to the full detection, just like in the other ones, where if it was positive, you proceeded to the full evaluation or referral. But we're trying to get away from too many of the referrals. We're trying to refine when the referrals take place. And what does a complete full evaluation in the toolkit look like? Well, this the toolkit has about 37 questions that lead you through various domains like memory, visual spatial, frontal executive, movement, those sort of things. And these are all designed to bring out red flags that would make you refer to a specialist, and also to reinforce, depending on the patient, answers that would be consistent with Alzheimer's disease. Okay? So just a look at what this looks like in the end. Once you've gone through the questions and you've looked at the answers, you're going to get 3 potential boxes, and I'm really sorry about that, to put them in. Answers consistent with normal aging, answers consistent with Alzheimer's disease, and answers consistent with needs a referral. Okay. Now, that's great. And at the end, you've done that for memory and visual spatial and all this other sort of things. I want to mention the key thing here is this is not like you don't add up the number of greens, the number of yellows, and the number of reds, okay? If there's any reds, you need to consider it might need a referral. If it's mostly greens and there's some definite yellows, then you might need to consider this may well be Alzheimer's disease, okay? And use the interpretation manual to help you. But just because greens outweigh yellows doesn't mean they're completely normal, okay? So what does it look like? In the original toolkit, this is the kind of thing you would be looking at. The question is, do they have difficulty recognizing people? And then they give various types of answers. So if they have difficulty recognizing the names, but they can recognize the faces, well, that's probably normal aging, okay? But if they, if they can't really recognize the people and the names, then that's maybe more consistent with AD, okay? But if they think their spouse is somebody else, whereas that could be completely normal in more advanced phases of Alzheimer's disease, if that's really early or the first symptom, that's really not typical of Alzheimer's disease and may need a referral. Could be something like Lewy body or prosopagnosia or something else. The new and improved and updated toolkit information will have forms that can be used for all of that, and I'm just going to show a couple of the early ones. This is the full cognitive evaluation, and it takes you through like even the earliest part of the interview, like let's talk, but give me a brief overview of things that have been happening. I need a better understanding, that sort of thing, and then it tells you if they don't give you enough clarity or detail, how do you go about getting some more of that out? And I think that's one of the benefits of this toolkit is it kind of leads you through a lot of the questions. And you might think, oh, this is going to take an hour. Well, early on, it's a little bit slower than once you get through. And we have residents at our facility in family practice, and they love this toolkit because they get very good at knowing how to ask questions of people who have dementia. They feel much more comfortable in the clinic. Things go more smoothly. So there may be a slight learning curve, but with the work that Dr. Rosen's group, which includes Cecilia Agapan, who's sitting back here, have been doing to kind of make this toolkit work in the clinic, and you'll hear later after me a panel of people that have been using this. It's been very helpful. So as you get deeper into this toolkit, again, the questions, do you get lost while walking or driving is another kind of visual spatial question. And if they're like not really engaged in that, they're like not giving you information, how do you get more information? Well, there's a whole list of questions that you can ask. Oh, yes, they're fine. Well, you're thinking, yeah, they're fine, but I really think I'm hearing more, well, does their motor vehicle show evidence of damage? Oh, yeah, well, there's a lot of dings and stuff, but I didn't think that was really related. But this is the way that you can have that little neurologist to tell you these are the kinds of questions you can use to bring it out. So I think this is one of the really strong points of this toolkit as opposed to other guidelines. And then in the easier to use new manual, the answers, the reference manual, it's set up vertically instead of horizontally like the other one. So in the original toolkit, you had your full clinical assessment that was done if not everything was green on the screening, okay? And you got to 3 boxes. If you went through the entire full assessment and everything was consistent with normal aging, great, typical AD, and needing a referral. And that's pretty clean and it's pretty easy. But in the new updated version, you have improved decision-making trees. Now, this is a little bit complicated. We're not going to go through all this today. But basically, there are some times if the test results are out of proportion, like let's say everything's normal aging, and they score very, very low on one of the screening tests that you do. And the toolkit covers a variety of screening tests depending on what you like to use. Now, we may have our thoughts about what screening test is better, and I think you'll hear more about that. But our toolkit allows you to use a variety of different tests and still use the toolkit. But if the cognitive test is way below what you'd expect based on the answers, that may be a reason to refer. Again, if you think it's AD, and yet their testing is like at the very top, that may be a red flag that you need to have a referral. And then if you have identified something like depression or sleep apnea or some of these other sort of things that you think, well, we need to treat this first and then bring them back, and it helps you decide, do they then have typical AD or do they need a referral at that point? And certainly talking about referrals if there's atypical findings just in the history. So after making the diagnosis, this is another place where we differ from the guidelines, many of them anyway. How do you give results? How do you disclose? What do you do about things that occur afterward? And in the original toolkit, and we haven't really updated these at this point, there are specific scripts. And this is an example. It's very small, so I apologize. But basically, where it says scripts to discuss diagnosis of dementia, there is some verbiage that could even be given to the patient verbatim, patient and family. I always recommend, and I'm sure you guys know, always have family members or caregivers or somebody there for two reasons. One, emotional support, and two, because sometimes the patients might forget what you tell them and they may need some help. But this has information that could be, if you wanted to, given verbatim or very close to that. I mean, most people don't just read a script, but that's there. It then has some non-italicized portions which kind of give you the reason that the script is set up the way it is and kind of helps you realize what not to cut out. And then at the very top, there's a box which kind of gives you an overview of what it is and provides bullets. So once you become very comfortable with it, it's just like, oh, I just need to remember these bullet points, and there I go. So what are the scripts about? Well, one is about presenting the diagnosis. How do you do that? Number two is about driving. Again, in the state of California, there's legal requirements. Treatment options, and how do you talk about that? And this does not cover any of the new meds that are coming down the pipe. This covers things like cholinesterase inhibitors and memantine and that sort of thing. Behavioral symptoms. There's a script to talk about how to talk about the family, with the family and the patient, about how do you deal with behavioral symptoms. Now, is this the be all and end all and solve all your problems with behavioral symptoms? I wish. But it does provide a starting place to start the discussion with the patient and the family. And then also there's a script about how to talk to patients that might be interested in participating in research. So what's new and on the horizon? As I said, there is a state-funded grant that's spearheaded by the UCSF main campus. Dr. Howie Rosen and Cecilia Alagapa and Alyssa Bernstein are part of that. And here at USC Rancho, Dr. Sigal Gadan and we at UCSF Fresno are participating. So it's a 3-campus project. There are community partners at all of those, with all of those campuses, and you'll be hearing from some of the participants later about that. What is going on? Well, as I mentioned, we're revising it. The instruction manual has been revised, and that's that blue one that I talked about. The yellow reference and interpretation manual is being revised, and I've shown you some examples of that. And within all of this, the ease of navigation and interpretation is really being worked on, okay? There are some new forms. There's a pre-visit questionnaire that's still in kind of beta testing, so if that's something that families or patients can fill out ahead of time, that's very helpful. There's increased information about the selection of cognitive tests and increased help with interpretation, which is something that not all of the guidelines really do, i.e., how do you use it if the St. Louis or the slums is, 1 point below dementia, do you have to declare dementia, that sort of thing, because that's sometimes difficult to know for people who are not specializing in dementia. And then we're also addressing the issue of non-English speaking patients and translating this into a couple of languages, and also addressing the issue of what do you do with patients with low education, because you can't necessarily evaluate them exactly the same way. So that's what's new. I wanted to give some examples of what's available eventually, still in beta testing, a pre-visit questionnaire where the patients or the family might fill this out ahead of time, as I mentioned. Then the screening, detecting cognitive concerns, we talked about that. That one is something that's available both in this form and then the UCLA form. And the full cognitive assessment, a PDF or an editable for printing or editing, where you can take the questions and you can jot down notes on the patient and the informant's answers, and then use that to help you go to the interpretation manual. So the guidance on cognitive testing, as I mentioned, should specify how results should be integrated into the rest of the assessment, and how to use the cutoffs and that sort of thing. There's PowerPoints. There's general guidance about how to use and do this cognitive testing, as well as specific supplementary instructions for each test. And again, these are still in the research mode, but they will eventually be more readily available. Again, I'd like to acknowledge all of the California Alzheimer's Disease Centers for the development of the original toolkit sponsored by the CDPH, and the grant implementation group that spans the 3 campuses, spearheaded by the UCSF main campus, along with the community practices that are engaged in this work. I'd like to acknowledge Ms. Cecilia Alagapan for the updated toolkit resources that you will have access to, and again, Dr. Howie Rosen for the slides that I used. And I think we probably have a minute or two for questions, so. Yes. Yeah. Mm-hmm.
So my question is,
Oh. Sorry.
thank you. So my question is, and my name is Linda, I'm a clinician. Shout out to the social workers. When we're talking about early detection, and even in the previous talks that we've had, is there any data, any research about, we have ADHD in our children, executive functioning, and then undiagnosed adult ADHD. Is there any research, any correlation with that? I just lost my train of thought. In terms of like early detection, like kind of the forgetfulness or the, do you understand what I'm saying? Like where I'm going with this? Like,
So my understanding is that you're wondering if ADHD pre-morbidly would make it more difficult to, or end up over diagnosing something like Alzheimer's disease?
yeah, like has there been any type of, I know it's not like specific to what you were talking about, but
Right.
in the tool, as we're talking about toolkits
Yeah.
and screening and all of that, has there been any research? I'm curious, really, is there any research that's been done?
I must
that
say
area?
that's not an area that I'm intimately familiar with, so I'd have to say I'm not sure about the research, but what I can say is this. If this comes up, for example, in our practice, if there's, if the patients and the family say there's a very strong history of ADHD in this person, you're going to be looking at the history more recently and looking for progression, so that'll help you. And B, there are always neuropsychologists who can help to sort that out to the best degree that they can, so that's how I would approach that issue. But I'm not intimately familiar with the research specifically with ADHD diagnosis and Alzheimer's disease in this setting. So good, thank you. That's my neuropsychologist on my shoulder for that sort of thing. So I like to pull out different, clinicians. So, other questions? Well, thank you very much.